tonight. So welcome to pediatric nursing. I mean, all of you should be extremely proud that you're at this point. You know, you've gone through Med-Surg 1, most of you, and OB, and that was rough. And I mean, pharmacology, that is a bear. I taught it for many years, so I know what pharmacology is. And then there's health assessment, and there's foundations, and then it's all those prereqs you had to do to get here. So congratulations to all of you. Now, it comes a really rough semester. Most of you have pediatrics, community, and Med-Surg 2. It's going to be rough, and it's going to be hard to separate all of those subjects and give each subject the due time it needs. Most of you will pay more attention to Med-Surg 2, and I know that. So when we are doing pediatrics, please do not get behind, and I'm going to tell you the best way to succeed. Before you come to class, look at the interactive lecture on your modules. That is like like looking at what subjects we're going to look at. It's like reading the book, okay? Then you come to class, and I'm going to teach mostly what's on that PowerPoint, and I'm going to give you stories about things I've seen, children I know, to make it understandable for you. And then when we're done with, you've seen it once at home, you've seen it once here, I'm going to do a Kahoots. Now the Kahoots are questions, and it's not just going to be I read a question and you answer it. I'm going to tell you why that answer works, why that question, how to read that question. So trying to make you think, because this is the semester you need to start to think, putting A and B together and getting C. It has to start clicking now, because by the time you get to capstone, it's going to be rough. Do not get behind, okay? You do have some things that are open that you can do ahead of time. You can do the NCLEX questions, but don't post them till they're on time, okay? Because we need to have that contact in Canvas, at least 2 each week. That's your attendance for the week. You also have Kaplan open. I do not need screenshots of Kaplan. I go in and I look. And I'll give you a little hint. There is a math due week 9, and then pediatric ABC due week 10. I do not look until after week 10 to look at all of them. So if you don't do the pediatric math before, don't fret, because it's going to get rough. You're going to have these projects for me, for a pediatric assessment, and you're going to have projects for community. So take your time and plan it very wisely. It's going to get rough with simulations and also with your clinicals. So we'll get you through. Now, things happen in your life. Something's going on. You can't get something in. The key thing with me is communication. Let me know what's going on. I can help you. If I don't know before, I'm sorry, I can't help you, because as a nurse, if you see things happening, aren't you going to tell the doctor before the patient codes? Oh, yes. So before you code and don't get an assignment in, tell me first. Okay, that's all I request there. So this week you have to do the technology quiz, the syllabus quiz, and register for your ebook registration on VitalSource before you can get into the modules. Your discussion question is due tomorrow night at midnight with 2 peer reviews by Sunday. The discussion question is 2 parts. It's not just tell me who you are, why you want to be a nurse, and any questions. There's also a question there about nutrition, cognitive and development of children in there. Nutrition is the biggest thing in pediatrics. Children must get proper nutrition or they don't grow. And I'll give you an example. If you have an infant born at 7 pounds, they should be 21 pounds or triple the birth weight by 1 year, because look at them. They go from not lifting a head to running by their 1-year-old usually. So do they need nutrition for that brain and for the muscles? Oh, yes. So nutrition, nutrition, nutrition. And then, of course, it talks about community things that are available for everybody, because even pregnant women, you know, need to eat properly. So every class, I will be doing a PowerPoint. and I'm going to infuse a lot of information and experiences in it. And then we're going to be doing a Kahoots. I will be recording, which I am right now. You will get the recording tomorrow by early afternoon, and I will attach the link to the Kahoots. Now, what are those Kahoots? I have gone through and found out concepts that are on exams, quizzes, and your HESI. And I have made questions that sort of address these concepts. If you're following those Kahoots and understand them, and you can use them in many different ways, you're going to pass this class and do very well. So Kahoots are very important. I spend a lot of time making sure you're getting those concepts that you're going to see again. So there will be no surprises. You're going to see an exam question and you're like, well, I remember that. There was a Kahoots, or I remember the PowerPoint. She said this, it's on that. So if you go back and every week review that Kahoots, you'll be good. What else? I do have a YouTube channel. It's Professor Bogart, Pediatric Nursing. Every single recording I have ever done is on that YouTube channel. You will see yours is Tuesday, 8 to 10 p.m. Eastern Standard Time. That'll be yours. If you want to listen to another one, go ahead. Maybe I talk differently. Maybe it was another experience. I don't know what I'm going to say. I mean, there's so many things I could say in different ways, right? You don't like just as a robot say the same thing. So they're there. You will have exam reviews. Those exam reviews are done by all professors, and all of them, of course, will be posted also. I try to do mine early. Probably on Wednesday nights, I'll be doing exam reviews, or Wednesday afternoons. I'm going to find out, what time is better for you all. But remember, they are posted for you. Any questions going on so far? Okay, so today, what are we doing? I'm going to be doing, first of all, the PowerPoint from the dean. David, are you with me? Can you turn your camera on, please? I don't like looking at a name because you're not there. So I like that. Thank you, David. Welcome. Okay, I appreciate that. As I'm doing lecture, I do look at your faces to see, are you understanding me? Are you getting it? Is it something that, I feel that, okay, they're shaking their head. All right, I understand. So your faces mean a lot to me, okay? All right, let's go ahead. Again, if you need to get something to drink, you need to eat, go to the ladies' room, please take care of it, all right? Let's go with our Dr. Brown PowerPoint. Now, if you are in community, you're going to hear the same thing. I'm not going to go over it in depth. You have it. I've attached this to your first week announcement, telling you all about what we were going to go over. And it's also when you showed you my Zoom links, et cetera, okay? So online learning, the thing is, we're online, we're Zoom. It's less personal, but if you need something, please, I will get with you. Send me a message and we can meet when you need to. I can work around your schedule with my schedule, okay? I want to help. I want all my students to pass. I don't like students to fail on me. I don't. I like you all to be successful. So I will work with you if you ask for help. Now, I am the lead pediatric professor. I've been with Fortis since 2017, originally online. I was telling some of you at Cutler Bay. And then I became completely online when the online program started, 2 years ago now. And I really enjoy working from home. Now, if you can't get a hold of me, something's going on, or something I'm doing you don't like, please, and don't hesitate, I'm not offended, please go to Dr. Brown, Darlene Brown, darlene.brown@fortiscollege.edu, or her phone, leave a message. She responds quickly. I also respond very quickly to messages or email messages, Canvas or email. Now, what if you're having a moment? You need to tell me something right now. Maybe your kid just got, you called from school, your kid is sick, you got to go pick them up, or you go into the ER, you can't get there, you can't come to class. use my cell phone. My cell phone number is 305-951-8055. And it's on the welcome page under my biography, and you can read about me there, okay? I've been a nurse for 40, let me see, how many years now? 46 years, long time, forever and ever. So again, contact me, via messages on Canvas or email. If I don't get you quick enough, you can, of course, call me or text me on the telephone I just gave you. Again, always be professional in everything you do. Now, everything that I have set up in your course opens up at Monday at 12 a.m. So, for instance, next week is quiz number 1. It opens up at Monday at 12 a.m. and it closes at Sunday at 11:59 Pacific time, which for most of you who are Eastern time, which will be 2:59 a.m. I mean, I work nights forever, so sometimes I did things at work. So I'm letting you know all of those things. Again, submitting stuff, try to be on time. Try to get it in by the due date. If you can't, for some reason, let's say you were going to do it, it's Sunday night, and you are going to the ER, or you're in an accident, or something happened. If you let me know before it is due, send me a message in Canvas or an email. I can say, all right, I'm going to give you a 2-day grace without a deduction. If I don't hear from you, you will get a late penalty, which is 10%. And it's only 1 week. Now, assignments after a 1 week late, I will not accept any of them. There'll be a 0, unless you have this, excuse that you just ended up in the hospital in surgery or something. Those excuses, we do pay attention to those, and we understand things happen. But after 2 weeks, it will be a 0. Homework can fail you. I had one homework fail last semester. She didn't get her homework in on time. So please don't let that happen to you, because it hurts me when she passed the KGA, the quizzes, exams, and ESSE, and then she failed because her homework wasn't in. So don't let that happen. Every NCLEX question is 1.25% of your grade. Every case study is 1% of your grade in the subjective part. And that project I was talking about is 6% of your grade. So 20% is all of this homework stuff. It does make a huge difference. Now, I was talking about you can do and work ahead, okay? The only thing I don't want you to work ahead on is case studies, because I want you to do the case studies when we're studying those diagnoses. I think it makes a better impact and you remember it better, okay? But everything else is basically open. The project is a pediatric assessment, and that pediatric assessment is a pediatric diagnosis that you choose. Let me know what you want to choose. I'll approve of it. And then you do a 3-part thing. A small paper, only 250 APA words. That's all, 250 words, very small. Explain what the diagnosis is. Then there is a handout, which is on your modules, of an assessment. It goes all through the body systems. Now, don't put something like cardiovascular within normal limits. I don't want to hear normal. I want you to hear regular heart rate, no murmurs. Give me a cardiac assessment. If you are giving me a paper on asthma and you're doing the respiratory system, don't tell me clear lungs. Tell me what an asthmatic child would sound like, okay? And then the third part is a teaching. Now, the teaching is teaching something to the child or to the parents. It could be teaching them about autism and how to work with them and how to keep things scheduled, or it could be about asthma, preventing triggers, or how to use one of those meter dose inhalers or an aerosol. It could be about diabetes, checking blood sugars. 5 slides is all I want on a PowerPoint. Don't go crazy. You don't need 30 slides. I'm not asking for big. Just give me concise, precise information that you would give to a parent or a child to help themselves take care of themselves as they go home with this disease that you have talked about. I have found that if you choose a disease that is personal, could be your child, could be you, could be your sister, your neighbor, your uncle, your aunt, mother, father, whatever. If you choose something personal, I've seen the nursing students who have done it really enjoy doing it. That is due week 8. Does that mean you can work on it now while you have a little bit of time? Oh, sure you can. Now, what I do with that assignment, it's 6% of your subjective grade. If you turn it in early, I will look at it and tell you what needs to be improved, send it back to you. If you improve it and send it back, I'll give you a better grade. So you can get 100, okay? So that would be your goal, because in these objective grades, if you do well and you have a 78, let's say with those other grades, you can get out of this course with a B. And I'm sorry, I want a B, not a C+, right? So make sure your subjective grades are as good as possible. Now, when you're submitting these things, make sure there's 2 submissions on Canvas per week. What does that mean? This week is critical because you only have discussion posts, but you have your attendance attestation. So after class, right before it's done, I'll say, okay, guys, please sign your attendance attestation to get it done. That's one time that you put something on Canvas. The second time is when you do your discussion questions. Now, if you don't have 2 points of contact on Canvas for 2 weeks in a row or 14 days, they will drop you and they do not have to notify you. Now, I go back and I look, especially these first couple of weeks, looking to make sure your attestations are signed. But you can't sign them until you see the class, until you're here. Or if you have an excuse that you couldn't come and you had to watch the recording, and I know about it, after you watch the recording and do a couple questions I'll ask you about, then you can sign the attestations. And you know, when I ask you questions on this missed class due to it was your husband's anniversary with you, it was your child's birthday, whatever it is, those questions actually will help you in exams and HESIs, because these will be concepts you'll need to know as you go forward, okay? So don't look at, is it a punishment? Actually, it's actually helpful. Again, if you don't document it in there, it's not done, just like nursing. So make sure you do what you need to do every week. Come to come to class prepared and you'll be good. I do not write a lot of announcements. I only write what you need. Okay, I will tell you, this is the information for week 1, week 2. This is the recordings for week 1, week 2. So if you see an announcement from me, please read it, okay? So make sure that you look at your syllabus, print it or keep it somewhere, whatever way you work with it, whether electronically or in a paper form, whatever you do. Make sure you do it and you check off the assignments as you go, because it is your Bible. I do follow it exactly, okay? These online Zoom classes are mandatory. If you need to miss it for any reason, you need to tell me before, okay? I understand things come up. I get that. Just let me know. And if you're having like a thunderstorm, or if you're having, you know, an outage, snowstorms, and sometimes up north it happens, hailstorms, let me know. Your phones work usually during that time. So send me a message, okay? Let me know if there's an issue. Now, I will do review sessions, I will do tutoring, but you need to ask me. If you're not getting a concept I'm talking about, send me a message. Say, Professor Bogart, you know, I really didn't understand this. When can we get together? Now, I don't need an hour of your time. It might be 15 minutes is all you can give me. I'll take it. Ask me your questions so we can get you understood. one of the ways I tutor too is I actually am a very good dosage calculation tutor. And if you go to my YouTube channel back in January, February, March, one of them, I did a dosage calculation video. It is excellent. And if you want to go back because you don't get it, I'll send you the 3 handouts that go with it. Watch it, then come to me and I'll tutor you. And you go, that's easier than I ever thought it was. Okay. Now, I don't do ratio proportion. I don't understand it, but the way I do it, it's extremely simple. So I want all of you to get completely perfect scores on your math, the calculations on your exams. If you're not, please reach out. I'll help you. So we know 80% of the grade, you need a 78 to pass this course. That's the exams, quizzes, and the HESI. Once you get that 78, we'll put the homework in. Now, for the first 5 weeks, I don't turn homework on. You know, and there's case studies and there's NCLEX questions and whatnot that you're turning in. On week 6, I'm going to turn it on and show you how those grades are affected by your subjective grades. And then I turn them off right before your third exam and right before the HESI. And I do not turn them off again until after that HESI is remediated and everybody is done. All right, quizzes. Now, my quizzes are timed. They're 15 minutes. They are 10 questions, and you cannot go backwards. You can only go forward. Now, we've had like these, if you see this, do not leave your laptop open with little fingers. I've had children come up, a mom goes to the ladies' room and they sit there and they play with it and they go through the exam and they got a 20. So it's happened. So when you see those little fingers, it's happened, and it happened to me once. So I'm sure it's happened to many other students. So be careful. When you want to do your quizzes, sit down and do those 15 minutes. Don't get up in between. And I highly suggest do not do your quizzes till after class. In class, I will go over every question. Now, I'm not going to say this is on the quiz, this is on the quiz, but in that first almost hour of class, you're going to hear all the answers to all the questions of it. So if you come to class and you listen, you're going to do really good on the quizzes. And the first quiz has a lot of theorists in it. If you noticed, I sent you a handout on Erickson and Piaget. These are the theorists that look at children the way that they act and why they act the way they act and the way they think, okay? Exams are going to be through ExamSoft and they're going to be Zoomed. If you have accommodations, let me know now before exams so that I can give you that extra time. Also, I need to give you extra time on quizzes. Let me know before so that I can give you what you need, okay? In exams, if you cannot make the day of exam for whatever reason, I've had children, I've had students with COVID in the hospital, having surgery, their mother had heart attacks, all different things. And they said, I just can't take my exam today. Tell me before the exam day, which is on your class day. I can move it to another day, another class, or it can proctor you by yourself. So let me know before and you don't get a deduction. But if you don't come to class, don't take the exam, and you go, oops, I forgot type thing, it'll be a minus 10%, and you must get it done within 1 week after class. So for you all, you have to get it done by Monday night of the next week, okay? All right, that's all that good stuff. That's everything I just said. Homework assignments. Again, make sure you write down, keep a schedule. I mean, I like written stuff. Some of you just put it in your phone and dial in what assignments do when. That's fine. Whatever works for you, but keep yourself organized. You know, I like to have those big pads with the homework and the calendar and write in what I have to do when. Whatever works for you. You've got 3 classes. It's going to be hard to keep up with. I mean, everything's going to come up on your calendars, yes, but whatever works for you to keep you organized, get it done. NCLEX questions are done usually around your exam time. There are 50 questions and they're 4 times. As I said, they are worth 1.25% of your subjective grade. So each one could fail you if you're on that mediocre 78, 79. So be careful. They must be turned in properly. So I don't want to see that green square box thing with it completed. I'm not accepting that. I want to see the whole list of what sort of questions you did. If you don't know how to do this, let me know, send me a message. I do have instructions. And it's as simple as that little green box that says print results. You click the print, and instead of printing, you change to PDF. You save it, and then you upload it to your assignment. There are some students who still don't know that. If you don't, it's fine. I've got information. I've got instructions. I'll let you know. NCLEX questions can be done as many times as you want to get there. Kaplan questions are the same. I don't care if you do them 4 times to get your 100. As long as that 100 has that remediation, and we're going to go into that. Again, no screenshots for anything. I do not accept them. Case studies must be done through the modules, and it's a one-time first attempt. So make sure you do the best that you can possibly do. As I said, each your case studies, each one of them are worth 1%. So be careful. Again, that can hurt you in the end. They should, like immediately after you do them, go over into your grade book. If they're not, let me know. There's ways I can look them up to see if you've done them or if they've transferred. And if they don't, I will tell you to write a help ticket so that we can make sure you get your grade instead of a 0, okay? Now, the paper we do is that pediatric assessment project. Just like discussion questions, they must be done in APA format. APA format means it needs references, which means that in the body of a paragraph, you're describing something, put a cite something. For instance, you can use your book. Your book is your best reference, right? So you put in parentheses, Perry, comma, 2022. That's your reference. Okay, as simple as that. And I do read discussion questions. I will let you know what you're doing wrong to try to help you get the best that you can do on those discussion questions. And again, you know, I'm going to send this assignment paper back to you, tell you what you need to improve on, and you send it back. Sometimes it goes back 3 or 4 times. I don't mind. If you're willing to correct it, I'm willing to score it again to help you get the best scores. And there is a rubric there. Exams and quizzes, make sure your stuff is plugged in and charged, especially exams, your cell phones. Make sure they're plugged in, okay? If something is happening and you're taking an exam and there's a thunderstorm in your area and you're worried about internet connections, let me know before. If you're taking a quiz and all of a sudden your internet just stops, let me know immediately by Canvas or an email. I can reopen stuff if you tell me immediately. And I'm telling you, each one of these quizzes and exams, I have timestamps that I can go back and look at. So I know that your exam stopped at this time and you sent me the email 5 minutes later. Perfect. I can help you. If you don't do that, I can't help you. Kaplan is due the end of the semester. As I said, there's math and there's pediatric A, B, and C. These things I have to go in and I have to look at. All I tell you is make sure you remediate. Even if you get 100, you must remediate. You might have a 30, a 50, an 80, and 100. I don't care. That doesn't bother me. It just shows me you really want to get a good grade. But make sure the one that you're putting in, that 100, you've remediated those questions, all of them. And you're saying, but I got them right. Why do I remediate? Well, you're going to remediate because you got them right, but did you really understand really why you got it right? If you read it, you're like, oh, that's why. And then you remember, okay? So it's there to help you. If you don't remediate and you got an earned 100, you're only going to get a 50. But I'll let you know you didn't remediate to let you go back and do it so you get your best grade, okay? Your HESI is week 11. Now, I've got some really good HESI Kahoots. There's 2 actually that I use, and we have a HESI PowerPoint. I also highly suggest for your HESI to go to that NCLEX pediatric section. It sort of fills in the gaps of things that maybe are covered on the HESI that you don't understand in the concepts of either the PowerPoint or on your Kahoot. So make sure you go back and look at it. And that's about all I have to say. Any questions about that? Good. Ready for your PowerPoint? All right, let's go. So we're going to go over chapters 26 through 30. A lot of information, but again, I put a Kahoots in the end, which is showing those key concepts that you really need to know, okay? So children, pediatrics. You know I love pediatrics, but I'm going to tell you something else. I'm an adult nurse too. I do adult ICU, adult open heart, adult ER, and I do pediatrics. So I'm that, both of them. Very rare thing I found out. I didn't know that before. So when I'm teaching you, I'm going to tell you what the differences between adults and pediatrics are. And actually, I've had nurses tell me that they learn med-surg because of the way I teach those different body systems and diagnoses. So I'm here to help. Now, healthy people came out from the government back, I believe, in Clinton's time, and it's basically trying to get the population healthier. So right now, 2020, what they're focusing on in children is that they are developing properly, getting good nutrition and oral health. Well, again, nutrition, without it, you're not going to develop. You're not going to be cognitively aware, and you're going to be behind. Also, if your teeth are rotten, can you eat? Are you getting proper nutrition? Probably not. So these are all intertwined. Part of the healthcare problems is obesity. I mean, children, it's a fast food society. We know that. Mom and dad have to work. It's easy to pick up McDonald's, go home, buy a pizza. We get it. I understand it. I did it as a single parent. I understand it. But then the kids have all of these electronic devices, I call them, and they're not up and out and moving like they used to. You know, children do get injured because they have absolutely no filter. They go out and do it and go, oops, I didn't realize that would happen. As they get older, violence and bullying. And of course, children do have mental health problems. And you're like, do they really? I've seen serious mental health problems in children. I've seen serious paranoid schizophrenia in a 6-year-old. I mean, depression probably is the most blatant of all of them, but there are children who do suffer, and we need to understand that and take care of them. I mean, these pictures tell you everything of injuries, guns laying around, South Florida. Now, I've got a grandson. He's almost 6 now, but the first 3 years of his life, he lives with me, and I have a pool in my backyard. That child by age 2 was doing front flips in the pool and could swim without swimmies on, okay, by himself. And he knew how to get to the edge or somewhere that he could save himself. But he'll never, ever, ever go in that pool unless I or my husband says, okay, because he's learned, because water safety is huge in South Florida. Pots on the stove. I had a brother who burned all of his arm with hot oil when he was a kid. And we know those plastic bags are bad, and kids love to get into medicine. And I think the biggest one they like to get into is their chewable vitamins. And actually, those chewable vitamins are not bad. It's bad when they are doing the Tylenol, which can hurt them, liver damage, or if the vitamins have iron, because too much iron can cause problems too. Health problems, the highest risk children are those that are premature, very low birth weight or low birth weight. You know, children born very early, they're born when everything's immature. Their lungs, their body systems, their brains are fragile, and so many things can happen to those premature children. And I did work in the newborn ICU, the cardiac ICU, and then the last 10 years of my career was in the emergency room, and I was a trauma nurse at Nicholas Children's Hospital in Miami. So I really know a lot about problems that occur with children. Children that attend daycare. I call daycare the place where children swap their spit. They have one toy that goes from this kid to the next kid in the mouth, in the mouth, in the mouth. Because how do kids explore their world? Through their mouths. How do infants soothe themselves? With their mouth, pacifiers. That's their self-soother, their mouth, their fingers, their thumb. This is the way children do it. So daycare, they're going to swap their germs with all the other kids. Then we have people living in poverty that are homeless. I mean, many families are one paycheck away from being homeless. And that's a reality of life today. Immigrant families, I mean, I live in Homestead, which is 1/2 hour from the Keys. And it's a area where there's a lot of more immigrant families because there's a lot of, vegetables and fruits that all need to be picked at certain times during the year. And those families don't go to an emergency room or urgent care until those kids are really sick because they're afraid we're going to deport them. And nursing doesn't deport people. They take care of the people. So, but they don't understand that. Children with chronic medical psychiatric illnesses. I mean, it is a chronic condition, requires a lot of patience and a lot of time. And then those barriers. I don't have money for the just the copay. I don't have transportation to get there. I can't get off of work. All of these things are barriers. Now, infant mortality is basically the amount of infants less than 1 year and less that die, whether in the first 28 days of life or after that. Now, infant mortality is something that is measured by the World Health Association, and it looks at these in all of the countries of the world. Now, you think that we would be the best, the least amount of deaths. We're not. We go behind many other countries. So we have a lot of catching up to do. Now, have we gotten better? Yes. I mean, in my career in pediatric nursing, it's about 25 years. So yes, it's gotten better, but there's a way to go. And birth weight, you know, children are born. The smallest one I've ever saw was 485 grams, which is less than 1 pound. And that poor little child went through about 3 months and then he finally died. But he went through, the lungs didn't work. He was intubated and then intestines didn't work. And the poor kid, infection after infection because of him being so small. Now, as they get older, death rates decrease. Now, infants become toddlers next, right? Ages 1 to 3 are your toddlers. Now, there are death rates in those ages because toddlers are the dive bomb kids. They go from the couch, they go to the coffee table and they're jumping, they miss, they get on the floor, they bop their heads. I mean, they don't know any fear at all. And as you get older, you're going to see those rates decrease. Now, mortality does increase when they're adolescents. Adolescents get a little bit braver. there are a lot more injuries with them, homicides. And then because of body image and they're worried about what people worry and they're not accepted into their groups, there's a lot of suicide. But homicide, firearms are big in those adolescents. So let's look at pediatric nursing and the philosophy of it. Now, in pediatrics, many nurses don't like to go into it. And one of the reasons is the families, not the child. It's the families. It's that mother who is like nonstop. Even the father, I've had aunts, uncles, grandmas, grandpas, they're overwhelming, but they just want to take care of the kid. They want the best for that child. So they seem like they're really, really demanding. Now, those were always my patients. Those are the ones my charge nurses used to always give me because I could handle them. What did I do? Well, I started teaching them and telling what they could do to help me, and which was helping their child, but it made my job easier. You know, just I want to know this, this, and that. You can do this, this, and that. This is what you need to look for. Now they feel empowered, don't they? And now they're happier because they feel like they're doing something, that they're aware, that they're knowledgeable. I mean, family is the one and only constant in a child's life. And those younger children would prefer mom, dad, or grandma taking care of them than a stranger, me, right? Until we build up to that rapport. And then family, what is a family? Well, it is whatever you say it is. There's all types of families. There's the traditional mom and dad. Then there are blended families. You know, my kids from a previous marriage and his from a previous marriage. There's two moms, two dads, there's grandmas, there's adopted. There's all sorts of families out there. Just remember, a family is whatever ever they say. Now, one of the things that we don't think about is culturally competent care. We've heard about this, and, working with med-surg. Culturally competent care is not that you have to understand, but you have to respect that people are different and they do things different from us. And we don't have to agree with it, but we have to give them the opportunity to be able to do those things because it makes them feel better. It could be those foods, vegetarian, or they don't eat pork, whatever it is. And of course, it's those rituals that they do. I mean, if we were in an area with more indigenous people, Indians, what about the medicine man and doing stuff like that? And then there's cultures that pray 6 times a day. Giving them that opportunity and respecting it, you will see those parents and that child will respect you more as a nurse if you give them the opportunity to practice those beliefs they believe in. Now, being a person who worked in South Florida for 40 some odd years, I moved from New York when I was 24 years old. So I've been here a really long time now. So when I came down, I had this cultural shock of a lot of Hispanic people. Then I married one, of course. But when you're working with this culture, you have to understand certain things. I would get children into the emergency room that had a fever, and grandma would be there, abuela, as the Hispanics say. And abuela would have that kid wrapped in a blanket, put a hat on their head and socks on their feet, and then they'd be dressed in 3 different cover-ups, and the kid's temperature is 104. So the first thing I do, take off the hat, take off the socks, take the, unwrap and get them down to basically a t-shirt and a diaper. And then I'd start to explain to them, if you have a fever and you hold it in with all that stuff, how is it going to get out and go away? Another thing they believe in is you can't walk on a cold floor without socks on. You can't do that. It's not good. You're going to be sick. Well, what if a kid has a fever? Walking on that cool floor can help assist bringing that fever down. It's like drinking cold stuff when you're sick, you have a fever. Oh, that you should have warm stuff. Well, cold stuff brings down the fever, right? So these are beliefs that I had to learn to practice in South Florida. And those are Hispanic are laughing because what I'm saying is so true. I'm an American gringa, American. So I didn't understand this, but I learned. How did I learn? I asked. I said, why do you feel that way? And they would explain to me, and then I would tell them why they should do other stuff. I mean, there's things like voodoo and witchcraft and evil spirits, et cetera, but it's something that we need to try to understand. And if we don't, ask, because that parent, that child will respect you more because you asked, because you didn't know. You don't have to know everything. I don't know everything. When I have a question, I ask, and that has built me a lot of respect. For instance, another thing, my husband is Jamaican, and that man believes in garlic and teas and all sorts of crazy things when he's ill. Now, do they work? Well, for him, they do, and it helps me too. But the only thing I say with drinking teas and doing herbs and stuff like that is that you know what that child is doing, because some of it can interfere with your medical care, like taking garlic or something of that sort. Garlic has an anticoagulant property to it. And if you have a problem with bleeding, you don't want this child to be garlic. So explaining that to that parent that, you know, comes from this culture who believes in these things, they don't mind not doing it, but as long as you explain it properly. Then let's get into some religious practices. Of course, I say, let them do what they need to do. Makes them feel good, makes them feel positive. Baptisms I've done for very sick newborns. I say, do you need a rabbi, a priest, a minister? Who do you want me to call to help you? Or do you have somebody to come in? It makes them feel better if you have an extremely ill, especially those newborns that come in. I worked cardiac ICU for 10 years at Nicholas Children's, and you would see how many times I get somebody in and it would make them feel better. Another thing that I've worked with is Jehovah Witness and blood products. Now, Jehovah Witnesses believe that if you give blood to them, that you are giving the soul and the body of the other person into you, and they don't want to contaminate you. It's sort of simply like that. Now, it's not my belief, but it's their belief, and they firmly believe in it. Now, they won't sign a blood consent. So you go out and you get a court order. You as a nurse still have to give that blood. Now, I've worked night shift and I've worked day shift giving blood to a Jehovah Witness infant. Usually, if it's night shift, if I can, and they're not symptomatic, I'll let the parents go home. And I'll say, call me at this time and I should be done. And I could tell you what went on. So they don't have to look at the blood. Well, what about day shift and the parents there? I have them step out of the room. I take the blood bag, draw it up, put it in whatever, put it on the child and cover it with blankets. And I don't leave any blood bags or anything hanging around. I don't want them to see that because it's disturbing. You know, I've had parents come back to me years later and tell me that they were so thankful the way that I did things. They know it has to be done, but you don't have to put it in their face, right? That's respecting religion and their practices. And the one thing about pediatrics, more than adults, I think, is that you're almost like a counselor. You're a counselor between mom and dad and grandma and siblings and everybody, you know, listening. We are that person who's teaching. They don't understand. They want to know. They want to help their children. So teaching, health teaching, and of course, injury prevention. Again, it's a lot of support. Sometimes you have children that, you know, you have to make that DNR, do not resuscitate, because there's no outcomes. They need to talk to somebody, and they can talk to you. And, you know, it's not that you tell them what to do, but letting them ventilate, it's what helps. So nursing care in children or adults is all about the nursing process, right? You assess, you get your own diagnosis, you make your outcome implementation, evaluation, and you're going to document. No, I said earlier, we talked about what happens with injuries, right? So the leading cause of death among African American boys ages 15 to 19 years is what?
Is
Firearm
homicide.
Firearms, and then I'd say the next one might be
Homicide.
suicide. But that
Suicide.
firearm homicide, yes, number one, right? And then of course suicide, because you'll find as we get into the adolescents are all about body image. They want to look good. They want to be skinny enough and the hair good enough and the clothes good enough. And that's part of it. But firearm homicide is actually the answer. You know, children grow, like I mentioned before. They start out with a 7-pound infant that can't even lift a head to a 1-year-old 21-pound kid because they triple their birth weight. And they're probably walking or close to walking at that age. They grow, they develop, they start using their hands, fine motor skills, gross motor skills. It's what we call interrelated, simultaneous, ongoing. In the first year of life, if you blink your eyes, that kid is already a young child. They're not a baby anymore by 12 months old. Now, there's different ways that we discuss how children grow, and it's going to be a part of your reading also. It's directional trends, sequential trends, developmental pace, sensitive periods, and individual differences. I mean, for instance, sequential trend means that they lift their head first. They roll from their front to back to the front. They crawl before they creep before they walk. These are things they do. Now, it doesn't mean they don't go from getting on their knees to getting up and already, you know, creeping around. Some children skip these steps, but as long as they're moving forward and what they should do is great. And then of course, developmental milestones, you know, grasping and turning and all of these things are a part of it. Their metabolism when they're young, I did send you a vital sign sheet. And that vital sign sheet shows you that an infant's heart rate at birth is 140 to 160 at rest. So what if you're giving digoxin to that infant and the heart rate's 100? Do you give it? Now remember, as an adult, it's 60, you don't give it. Call the doctor, right? 100 is too low for an infant. So please understand the differences in vital signs in the age of children, because you're going to see it reflected in questions, and you're going to have to know what is a normal heart rate or blood pressure. You know what a normal blood pressure of an infant is? 60 over 40. A 1-year-old is 80 over 50, 60. So knowing those things are going to help you take care of them. We know initially infants cannot regulate their temperature. What does that mean to us as nurses? That means that if we are looking at a newborn infant, a newer infant, and we need to do an assessment, we're not just going to uncover them and let them get cold, because we don't want to chill the infant. So you might just uncover those areas you need to keep them cool or warm, or put them underneath a warmer so that you don't have them get cooler. So that's temperature and that thermal regulation. Infants sleep a lot. All they do is sleep, eat, and pee-pee and poopy, right? That's it. That's what they do. And sometimes you get them on their tummy and tummy time, but mostly they should be resting. And again, single most important influence on growth and cognitive and development, nutrition, nutrition, nutrition. Now, one of the theorists, Erickson, talks about infants. And what he says is trust versus mistrust is what he talks about. And when an infant trusts you, that means when he cries, you go get them. They're fed, they're changed, they're burped, they're held, their needs are being met. That is a happy child, and their temperament's going to be good. That mistrust is those infants who don't get what they need when they need it. So they cry, 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 and nobody comes. And those are in certain situations, but Trust versus mistrust is all about Erickson. And that's one of the theorists that you're going to see on your NCLEX. You're going to see it on your HESI. They talk Erickson all the time. So I'll be talking more about it next week so that you get it. Freud is all about, psychosexual, talks about oral, all about, oral satisfaction initially. Erickson talks about the environment around them. Piaget is about thinking. Initially, how they have to see it. It has to be concrete. They've got to see it before they can start to understand it. And then as they get older, they understand that this happens, then they do other stuff to make it work even better, whether it's with toys or drawing or things, or, oh, look, these are all red. That's red, that's red, that's red. Putting more stuff together. And Kohlberg talks about good and bad and a consequence for each. We really don't go over Fowler, to let you know. Now, as I was telling some of you earlier, that I went to work and played every day. What do children do literally for the first several years of their life? In fact, they do it for a lot of years of their life. They play, they play, they play. Sensorimotor development, like the touch, they want to feel it. What does it feel like? Oral, in the mouth, right? Explore the world in their mouths. And then motor, taking the rattle and putting it up, moving it and hearing it shake. That is part of the motor. It does help with intellectual development. As they get older, they socialize, they become creative, and it's really a good thing for children to play and play as much as they like to play. Now, one of the things you need to understand and really look at is types of play. How children play and whether playing together or not is part of the understanding. All of these things here, one of the things I can say is, like, for instance, dramatic play. We use this a lot in the medical community, and this usually is used for that child who's some abuse, something's gone on. And you put them with maybe dolls or teddy bears or something and watch how they go together. And sometimes we can see what has been done to the child through dramatic play, okay? It's one of those interesting things. Now, this basically here describes play. Kids can play by looking at another kid playing, or playing by themselves, nobody around, or two kids next to each other, but they're playing by themselves, but not together with the same stuff, or associative play. They're playing a game together, but there's no rules. There's no outcome. They're building a sandcastle together, but you're putting things and they just keep working. Cooperative play is basically your board games, like checkers. There is a goal. This is what we're going to do, and I win when this happens. I get all of your pieces off the board. So those are different. These are things you need to know. Toys support children's enhancement. They really learn from it. And it's also great because I remember my little grandson, you're going to hear all about Christian a lot. Well, I remember as a little kid, he had all of these musical little toys, and we would shake and rattle things together, and we'd sing, I love Christian and Christian loves me, and we would shake things and do it over and over again. I mean, up to this day, when I started, he knows the words. And that was when he was 1.5 years, 2 years old. And also with toys, you put stuff ahead of them, they have to crawl and reach. So it's good for muscles and developing. Now, one of the things we do when we get children into the doctor's office or urgent cares, or like into, excuse me, into emergency rooms, is we're going to be doing developmental assessments. We need to know that that child is where they should be, and that's cognitive, okay? Because development is all about the way they think, what they can do. For instance, if you have a child who's 6 months old who can't lift their head up, there's a problem, right? They're delayed. Another thing, if they can't roll over front to back to front by 7, 8 months, there's a problem. So what do? Well, we tell the physician and we get early intervention. We'll have physical therapy, occupational therapy, speech therapy for some of them. And children are so resilient, they catch up so quickly. There's also different assessments we do for like this little girl on the left side. She has cerebral palsy. I can tell by the look of her. There's different assessments that we would want for her than we would want for this little girl on the right. You know, we know that there are conditions which change what assessments should be. And there's a lot of things written about it. And there's a lot of different questionnaires that we can fill out for that. Children can be born with cleft lips. They can be born with club feet. They can be born without arms and legs and fingers and toes or one ear. I mean, this is just part of congenital. Sometimes it was something that happened intrautero. Down syndrome is something. What if a child is born to a mother who had bleeding problems on Coumadin? That can cause problems. And Dilantin. I mean, we're learning more and more and more about what a pregnant woman can ingest that will not hurt their infant where they didn't know before. Alcohol, cocaine, lead, I mean, we've understood those. If being subjected to a person with rubella, and then of course, there's metabolic issues and chromosome issues. So again, role of the nurse. What do we as pediatric nurses, what do we do? Well, we know that if it's genetic issues, we know what this child is expected to be able to do. And then we're going to provide that education support. And then we're going to say, Mom, and this happened a lot in cardiac ICU, you have a little baby, you know, congenital heart defect. Let's say it is something as severe as a tetralogy of Fallot or a hypoplastic left heart. And these are pretty things that's going to need some good surgery. Now, this mom feels like, oh my God, it was that glass of wine I drank, or it was, I took Tylenol 3 times during the pregnancy. Oh my goodness, that's what it was. I always make sure I tell those parents, it wasn't anything you did. It wasn't the Tylenol, it wasn't the glass of wine. This is just something happened during intrauterine development, and there's nothing you could have done. And you know, it actually helps them relieve because they feel guilty. They did something wrong. And most of the time they haven't, most of the time, okay? And there are times when you have infants, for instance, cleft lip palate, and that lip is open and, you know, they don't look like a normal baby initially. And the parents, you can see they're afraid to touch that infant. I'll have the mother sit down, wrap the kid in a blanket and give it to him. And I go, oh, look at all this beautiful hair. And that nose is so cute. Try to get them away from this that they're seeing, that they're like, oh, that looks terrible. And then they're afraid of what other people will think, right? And then, of course, as we as nurses see that a child needs any sort of therapies, we're going to make sure they get it. Now, next week, we're going to talk a lot more about things like this: object permanence, pre-operational thinking, concrete operational thinking, and using abstract symbols. So this is a question that just put it in your mind, and we're going to study more next week. But a father tells a nurse that his child is filling up the house with collections. He has all these seashells, bottle caps, baseball cards, and pennies. And the nurse shouldn't recognize that the child is developing what? And what it is they know what shells are and coins are and this is and that is, and they're just trying to do collections. It's just part of being creative and them collecting their own sort of things. I mean, my grandson has 2 piggy banks. He has a penny piggy bank and a silver thing piggy bank. So his collection is that. And then of course, cars, little matchbox cars. He's got about 100 or so of those things. You know, I had to buy cases for him. These are his collections, and it does help him. Now, the one that I want to mention to you is object permanence. Objects permanence is you show a child, even an infant, so you show an infant a rattle, and then you put it at the end of the crib that they really can't see, they're going to go looking for it. As they get older, you take their toys, their doll, their truck, put it in the toy box. They know to go to the toy box, it's still going to be there. That means it's object permanent. That object is still there, even if you cannot see it. Now, let's talk about getting histories and physicals. Now, the one thing about pediatrics, we have children that are going to be up to the age of 21. So HIPAA is very important. Remember, an 18-year-old can sign their consent for admission to the ER, urgent care, doctor, everything. That parent needs that 18-year-old child's permission to get any lab results. And we as nurses need to respect that. If they're cognitively aware, they're, quote, normal 18-year-olds, you cannot talk to the parents. It must be to the child, unless the child gives you permission. Very important concept. Talking with families can be pretty hard. Just listen to them, keep directing them to what's going on this time, please, and be aware of cultural differences. There are cultures you can't look them at the eye, you can't touch them. I mean, I'm a touchy-feely hugger person, but there are cultures I can't, and I won't, and I understand it, but it takes time to learn that. And remember to listen. That empathy, just like I said, realizing, parents feel guilty, or that kid, is now 4 days being with a fever. They've been to the doctor, urgent care. They're finally at the ER. They're exhausted. They've been in a fever 4 days. That poor mother just saying, Mom, you've really been through a lot. You must be exhausted. And when you say that to a parent, I said, you're doing such a great job. I said, I know you're tired. So let's try to fix your kid now. And something, just because I identified that, yes, they're tired, they're going to do a lot better. If you have a patient and mother who do not speak your language, do not have the 16-year-old son or nephew translate for you. They're going to put their own opinion of what the translation is. Make sure you do it through an interpreter or through that blue phone, okay? Children, how do we talk to them? Number one, you must get on their developmental level. You can't walk in and go in and sit next to them and expect they're going to talk to you. So what would I do? Well, I see a little 3-year-old boy sitting there and he's got a Batman shirt on. I'm going to go, wow, do you like Batman? I'm going to say, wow, I like him too. My grandson does too. Maybe I have a sticker. I always had stickers in my pocket. Let me see if I have a Batman sticker for you. I said, that's pretty cool. I mean, sneakers with lights on. I'm like, do they light up when you walk on them? So now what have I done? I'm not threatening. I'm not threatening anymore. And before I touch them, I'm going to show them the equipment and maybe have the stethoscope on them listening to themselves or to me before I put it on myself to listen to them. Now, it takes a couple minutes, but that kid's not going to be running out the door, down the hall, and out the ER. I've had many children do that. And you're yelling, security, get the kid. And it happens. But if you do it, get on their level, take your time getting there, let them touch and play with the equipment. They're going to work with you. And it's on the level of each child. And I play games with them all the time. And these children are so honest. They're going to give you honest answers. So I'm saying, so tell me, why'd you come today? You have an ear hurts? And they'll go, my ear hurts. And they're going to tell you so honestly. So make sure when you're talking to whoever brings your child in, COVID has decreased the amount of people that are allowed in, but I'd had times where I had 10 people coming into the emergency room with a child. You have your aunt, your uncle, grandma, grandpa, the next door neighbor, best friend, and mother and father. It's like, okay, who am I going to talk to? Who knows what's going on? It could be, the best friend. The kid was with the best friend all weekend, or it could be with grandma. Okay, tell me what's going on. What are the symptoms? Chief complaint. As we learn that, then we're going to go into your kid was born, normal delivery, ever in the hospital, are they eating good? And of course, before we give any medicines, allergies, and any medications that they've had. And are their immunizations up to date reasonably? I mean, they're usually slightly behind because they had been sick. Fine. But if I have a 2-year-old in there with a fever and an upper respiratory and a cough, and they don't have immunizations, I'm going to worry about things like pertussis, right? But if their immunizations are up to date, I'm like, okay, I'm pretty good. I'm not going to be as concerned. I mean, always you protect yourself, but I want to know immunizations. And then, of course, looking at them, are they normal? Are they in normal growth and development? And a kid who's admitted, I want to know habits. Mom has to go and answer a phone call or go grab a cup of coffee, and the kid's alone and it starts screaming. I want to know that the teddy bear comforts him, or he likes this pacifier or this blanket, or what will calm that kid down? Does he suck a finger? If he sucks this finger, I don't want to put an IV in that hand. I want to keep it ready for that child, right? As we get into sexual history, we're talking about adolescence. We can ask parents to leave the room. And I've done it many times. And then I need to break open the ice with this adolescent. Like, so are you going to go to college? Or, hey, I hear you're listening to some music. What do you like? Or see something, break open. Or, are you in sports? Do you like music? What's going on? Break open some sort of topic, because I'm a threat just like the parents. And I need to tell them, I said, I don't have to tell your parents what's going on. I just want you to feel better. You've had 3 urinary tract infections in 6 months. Tell me what's going on. Are you sexually active? And you can't tell my mommy. I'm like, I don't have to tell your parents unless it's something that could be harmful to the child or to others. That's when I have to tell somebody. But then I could treat this child a lot better. How are they doing in school? Many times I will say, listen, what are you doing in school? Are you, what's your grades? And they'll tell me B's and C's. And I'm, oh, good job. Or A's and B's. It just tells me, that they're adjusted. Another thing is parent-child relationships. I mean, I've walked out of a room, and each room in this emergency room had a door, and it closed. And I'd walk in and they'd be on the stretcher, and the otoscope would be on the stretcher, and the little black ear things be thrown all over the place. And the drawer would be open, and there would be the alcohol pads thrown, and mom's there on the phone texting or doing whatever she's doing. Like, she doesn't have control of her child. So I know I'm going to have to help this parent, like, even give medicines to this child, because I don't know if they're going to be able to. And when we're reviewing the systems, first do the focus. If they're there with a cough, listen to the chest. If they're there with vomiting, diarrhea, listening to vomit, bowel sounds and capillary refill and heart rate, those things, and then go to the other systems as needed.
Professor, I have a quick question.
Sure.
So back to when you were speaking about the adolescent child who has had several urinary tract infections over a period of 6 months. Let's say, they're open and honest and they tell you what's been going on. At what point do you decide, let's say the parent, so what's going on? Why do they need this medication? How do you navigate that without breaking the child's trust?
Well, you just, urinary tract infections. I say, well, I taught your child, how to clean themselves better. If they're using pads, to change them more frequently when they have their periods, or things. I will focus it away to teaching. The adolescent, I'll teach her things like void after sex. Make sure you take a shower after sex. Tell her what she needs to do to help her. But I will tell the parent that I told them to do this, this, and that. I'm not lying because I've told them both, but I sort of not said all of it because that is a respect. Because my goal is to get that kid healthy. And it's not hurting the parent. I mean, I would never tell my parents either. Let me tell you, I'd be so afraid. My mother would beat me up. I had 6 brothers, I was second to youngest. I would be killed if I ever told my mother or if she had ever found out something like that. So, but really, that's a great, great, great question. And I've been confronted like that before, but that's the way I would handle it. Okay.
Thank you.
Oh, you're welcome. So as they're coming in, we need to know any food practices. Are they vegetarian? You don't want to put bacon on a kid's plate that's vegetarian. Or if they can't eat pork, you wouldn't want that. And looking at what they're eating and doing a good nutritional assessment is important. I mean, many toddlers, toddlers go through what we call physiologic anorexia. All they eat is macaroni and cheese and a chicken nugget and maybe apple juice. And parents are like, oh, I don't know if they're getting enough. And at that point, if I feel that they're neglected in their nutrition with the evaluation, maybe the doctor needs to order a multivitamin. And as nurses, this is what we do to help our children. We're going to be measuring this child, as they're older. We'll prepare them before the examination. Infants' head, chest, and abdominal circumferences are important. We know at birth the heads are bigger than the chest, and it's about 1.5 years to 2 years when they sort of meet up and maybe the chest is bigger than the head. But what if the head still keeps big? Well, is there hydrocephalus? Is there a brain tumor? It's things that we look forward to. Another thing that we do is always, always height and weight on every single child. And why do we do that? Well, that measures nutrition, doesn't it? The kid's growing and it's getting bigger. Well, hello, that means the kid's getting proper nutrition. We're going to look at all the vital signs. This is why you need to know what are normal vital signs for each type of child. And of course, looking through, all the systems of the body, the ears, the chest, the lungs, genitalia. I've had, infants that didn't have distended testicles, or we had females whose labias were fused together, and, teaching these parents what they could do to help these children. At birth, you are told an OB to make sure you do a rectal temp at birth because you want an accurate temperature, right? No, you're making sure they have an anus. Do you know there are some children born and they do not have an anus at birth, and they need to get a colostomy pretty quickly, okay? So, and then looking at reflexes, are they, with the cooing and the sucking and the startle reflexes, et cetera. And we're going to go into that more next week. Again, all the circumferences. Now, we did, and most places have these things where the thing comes down to measure a child's height. Now, a kid at this age is not going to be ready to do that. They think the kid's going to come down, it's going to bop them in the head, it's going to hurt them. So let's make a game from it. I get on it first, turn around, put my head down. I'm like, oh, I'm a number 7. Look right there. Okay, let's see what you can be. Here, make sure you hold that. Make sure it just touches your head. Look, you're a number 8. You beat me. Good job. I got a real accurate height, didn't I? Again, I'm playing games. Another thing is blood pressure cuffs are all different. They go from 00 all the way to extra large adults. Most of your children are size 4, size 6, and those are your toddlers, preschool, and early school age, and then it gets more. And most of these younger children, I will do D as my blood pressure, that lower leg, because it doesn't hurt, and I can distract them, and I can get an accurate blood pressure doing it this way. Putting it on their arm where we do it in the upper arm, it hurts. It hurts me. I'm sure it hurts them, put it on their leg, they don't feel it, and you distract them. Again, looking through all of their body organs is important. Now, pain. It used to be my biggest pet peeve that we didn't give children adequate pain management, and that we didn't feel that these young children, their nerve endings were good enough to feel pain. We've decided that, yeah, even the premature children have pain. So we know, even today, that children do suffer from inadequately treated pain because they're not getting it quick enough, soon enough, or not a dose that's proper. Now, we're going to give milligrams per kilogram like morphine. Now, for us, we're going to get 5-10 milligrams. It's like this big dose, right? But in children, it's 0.1 milligrams per kilogram. And newborn infants, just having surgery, they're going to hurt, right? So if 3-kilogram baby, 0.1 milligrams per kilogram, we're going to give 0.3 milligrams of morphine. That's like giving you 10 milligrams. That's how we give it. And then we give it diluted, we give it slowly, and we give it when it's due. These children do not need suffering, but we also need to evaluate it. Just like adults, we've learned this in pharmacology, chronic, recurrent, persistent pain could be due to surgeries, braces, ears infections, and whatnot. Now, measuring pain. Now, we can see those little faces scale. It's great. I love little kids when they push to their little faces when we say, well, this one means that you don't hurt at all, but this one means it really hurts a lot. Which face looks like you? Now, we do not use faces until they are preschool, age 3. And we're going to use that up till age 8, and then we're going to go to numeric. These are other ones we use, but most of the time it's faces, flax, and numeric. So flax, the bottom one here. What it does is any nonverbal child, it could be a cerebral palsy who's 18, or it could be somebody less than 3 years old. Their face, the way their legs are moving, the way they're just wiggling and hurting and crying, and they're not consolable, that is flack. We can really accurately give them a pain scale, which is true and real. According to your book, numeric shouldn't be used till a child is 8 years old. Have I used it at younger children? Yes, but according to your book, it's 8 years old. We know that if a kid who has pain, all they're going to remember is pain. They come to the hospital, all they're going to remember is when they go to the hospital, they're in pain. So they really need it controlled as much as they can. Children who can't verbalize things that are cognitively impaired, there are checklists that we can use for them. And remember, pain is just not managed just by medicine, whether you're an adult or a child. Distraction is great, which means here, let me blow some bubbles, watch them. Here's an iPad, here's a sticker, or anything, music. I've done all sorts of great things with distraction. And then this little premature baby, I love this picture. Many premature babies who require to be ventilated for long periods of time tend to get really irritable and they don't get comfortable. You put them on mommy's bare chest, all of a sudden the heart rates go down, their respiratory rates go down, and they fall asleep better than they've had for 24 hours. This non-pharmacological pain management is probably one of the best, the distraction and the kangaroo care. Another thing, kids, just Tylenol sometimes works on them, you know, or non-steroidal anti-inflammatory drugs. Remember, Motrin, ibuprofen, cannot be given to an infant until they're 6 months old. There's something to do with bleeding coagulopathies and platelets that these younger children cannot tolerate it. Only Tylenol for the first 6 months, and it's 10 to 20 milligrams per kilogram. Very simple, right? And then we'll do Motrin later. Remember, there's also positioning. There's hot packs, there's cold packs, head of the bed up, pillows for abdomens, so many things besides pharmacological. Now, this little girl's just about to get a laboratory test. They come in and going to stick a needle in her arm. She's smiling. Why? She's got EMLA, a numbing cream, underneath that little plastic Tegaderm, and it's numbing the area up. So when they take it off, wipe that white cream off, they put a needle in there, she's going to feel the touch, but it's not going to hurt. And she's happy because we provide atraumatic care for our kids. We know pain comes from all different things, teething, immunizations, circumcisions, but trying to relieve them. I mean, my grandson had a circumcision at 1 month old. His foreskin was too tight. We had to do it. I couldn't get it down. It was too tight, had to come down. They gave him a pacifier. They call it a non-nutritive sucking device with a little bit of sugar water on it. And there's a study by Harvard neurophysicists that said this pacifier with sugar water works just like morphine. And I remember him crying, but it was not long at all. I mean, it was less than 20 seconds and he was done because he just self-soothed with a pacifier. We know sickle cell is one of those that hurt a lot. Making sure kids get what they need, right? Pain, treat it. Kids, they do hurt, and giving them proper dosages. So that's your first lecture. I'm going to go now and we're going to do our Kahoots. And we should be done a little bit before time.
I had a quick question real quick.
Yes, ma'am.
Going back to the circumcision, so I actually watched one at my last clinical and they did the sugar water, and the baby was crying, stopped for a little bit, and then as soon as it was over, he stopped crying. But my thing is, does that not hurt continually afterwards? Because it's still an open wound, you're wearing diapers, you're having it cleaned and messed with. So how would you deal with their pain afterwards?
Well, afterwards, we can give them Tylenol, and it works really good. Because remember, they've never had pain medicine. Also, putting that ointment on it, that will take it and protect it from urine getting to it, also helps. I know that my grandson, and he lived with me at the time, didn't complain of it afterwards. I kept it gooped up really good, though. I mean, really, I used like too much, but I know that that's what he needed. So very good question, though. I agree with you, but Tylenol works amazing on infants. Even Motrin on those younger toddlers with earaches. Within 20 minutes, they are running around the room. They're happy. And they come in and they're crying and crying and they're holding their head and they don't want a hot pack or a cold pack. Give them some Motrin, the proper dose, and they stop crying. Kids are resilient. Kids are great. So I'd like you to try to put your names there that you're going to know, because let's say you want to get with me and do tutoring, and I can go back and look at Kahoot gains and I can see what questions you got wrong and I can help you understand the right questions. This Kahoots is also going to have some of the concepts from next week. So as you're looking at your interactive lecture or you're doing the reading, you're going to see these things. So it's going to help again to put those concepts here. It's going to reinforce it, okay? I don't expect you to know all the answers today, but I'm going to help you try to remember them. From a worldwide perspective, infant mortality in the United States, that means how many infants die by age 1? According to the world. Is it good? Is it bad? What is it? We know that infant mortality is higher than many other countries. I mean, like Switzerland, Norway, actually, those are some of the big ones that they have one of the lowest. And this is measured by the World Health Organization, WHO they call it. So we can get better. We've gotten better, but we need to get even better. The leading cause of death from unintentional injuries in children. So means nobody inflicted injuries, you know, kids, things happen. The leading cause. And it's actually motor vehicle accidents. And it's not just being in a car seat that's not done right, or not in a car seat, in a car driving. It's children getting run over by cars. I've seen several children come in to the emergency room that were ran over by aunts, next door neighbors, and mothers and fathers. I've seen some children have no injuries at all, and I've seen other children with massive internal injuries. So it could, and why they don't, I'm not sure, act of God or whoever you believe in, but amazing things. But motor vehicles are the biggest in any age group of children that we're going to talk: infants, toddlers, preschool, school age, or adolescents. Which statement is most descriptive of the pediatrics family-centered care? Remember, you just don't take care of a kid in pediatrics. We know the family is the only constant in a child's life. And as they get older, slowly they're pulled away by family, and they get to friends and then school activities. But in the very beginning, it's the only constant, and will be until they move out of their homes. The major cause of death for children older than 1 year old is what? Remember, 1 year old, I call them my toddlers. I call them my dive bomb kids. I'll never forget Christian jumping off the couch, trying to get to the hassock, missed it, fell off, bumped his head, and had a lump this big. He never did it again. Unintentional injuries. The nurse caring for the child in pain understands that distraction, whether it's stickers, music, iPad, bubbles, anything. I used to play music in the newborn ICU at night, and my kids would sleep all night long. Remember, anything that you use for a kid must be based on the child's age, developmentally appropriate. They don't understand it. How can you take their focus away from pain? They got to understand it. So developmentally appropriate. You'll see that a lot, developmentally appropriate. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? That means you don't win. There's nothing you do to win. You're just doing the same things together, playing it, making up your rules as you go. And that's called associative. Cooperative, when there's a goal, like checkers, somebody wins when this happens, okay? Associative is two kids playing together. Parallel, they're both playing, but they're not doing the same thing. Which statement best describes the process of critical thinking? You know, you're taught when you go to nursing school, you need to understand critical thinking. And you're like, wow, what is that? Well, if you need something to eat for dinner, you look what's in the cupboards, you go to the grocery store, buy what you're missing, go home and make it. That is critical thinking, okay? So it's purposeful and it's goal directed. You know what you need to do, what you have to do to get there, and then you do it. What is probably the single most important influence on growth at all stages of development? Nutrition, 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 nutrition. They're not eating right. They're not going to grow the way they should. Cognitively delayed, developmentally, everything is going to be delayed. Frequent developmental assessments are important for what reason? Why do we need to see if they're lifting their head and turning over and then grasping and pincer grasp and building blocks and walking? Why? Why do we need to know this stuff? Because we want to know if there's delays. And if the delays are too much, we can have early intervention, physical therapy, occupational therapy, speech therapy, and we can catch them up quick because kids are beautiful. They kick up really quick. Which function of play is a major component of play at all ages? I mean, you have a kid there sitting there with blocks and touching them and feeling them and putting them together and sticking them in their mouths. It's what kids do. It's called sensoromotor activity. What do they feel like? What can I do with them? Putting them in their mouth is just, they explore their world in their mouths. It's also part of what Piaget says too. 3 children playing a board game would be an example of what type of play? Like checkers. I was just playing some Sorry Paw Patrol with my grandson, who'll be 6 in January, and the kid won. It's called cooperative play, and he won without cheating, because I don't like cheating, and his grandfather wanted to win, and the kid won 2 games. Head to tail growth of development is referred to as what? So you lift your head up and then you turn over and you walk and you crawl and you get up and you walk on your feet. Head to tail. What is it called? It's called cephalocaudal. Cephalic, right? Head, cephalic, cephalocaudal. And caudal is when you use your lower extremities and you walk or crawl. What is the single most important factor to consider when communicating with children? And get on their level. You can't walk in and start doing anything. Get on their level, talk to them, break their ice, let them play with this stuff, and you're going to get it done really easy, or they're going to be running down the hall and out of the place. What 2-year-old child pain assessment tool should the nurse use? 2 years old, which one? Remember, FLAC starts at preschool, age 3. The faces. FLAC is that nonverbal or up to 3 years old. So a 2-year-old is definitely a FLAC tool. According to your book, FLAC up to preschool, which is age 3. And then faces take over, and then age 8 is numeric. At 6 months, an infant's birth weight should do what? What do you think? So by 6 months, it should double. By 1 year, it should triple. Okay, those are things you need to know in order to answer some questions that you will see. The first expected fine motor developmental milestone for an infant begins with. Now you're going to see fine motor and gross motor. Fine is F, think about fingers. Gross motor is get up and go, go, go. Okay, so that's the difference. Fine motors is palmar grasp, pincer grasp, making little objects, building blocks of two. And you'll see this when you read chapter 31, when you look through it. So the first thing they do is you put your finger in their palm, and by reflex, they put their fingers around it. And mom thinks, ooh, look, they're giving me a hug. I would never tell them differently. As they get older, it is voluntary. Then it gets crude pincer grasp, fine pincer grasp. Then you're going to have towers of 2 blocks and putting it into containers. An 8-month-old should be expected to perform which fine motor skills? F, fine fingers. Palmar grasp, pincer grasp, putting things in a container, and then a tower or 2. Those are fine motors in the first year. By you are 8 months old, it should be getting that rattle, being able to shake it, put it in her mouth probably too. And then of course, crude pincer, not like that little tiny, getting those little Cheerios off of the high chair, right? The natural physical developmental sequence that most children follow is what? Excuse me. So the first thing they do is lift their head. Then they go from front to back, back to front, get up on their knees, they creep, they crawl, they cruise, and they walk. And that's the sequence, and everybody's different. Which behavior indicates that an infant has developed object permanence? What did I tell you about object permanence? So this is when you have a toy, you show it to the child. Even infants are pretty smart. You'd be surprised. You put it somewhere else and they go looking for it, even if they can't see it. So even if it's hidden, the child still knows it. Even infants knows that. Object permanence. In general, an infant should triple their birth weight at what months of age? Excellent. Good job, guys. You've been listening. I love it. Perform a head to toe on a toddler. Most important to consider before beginning the examination. So toddlers ages 1 to 3, they really don't like strangers. Excuse me. Get on their level first. Don't even try to do anything. Just get on their level first and then have them touch and feel the equipment and then have them help you do it. And they will. They're very smart. According to Piaget, toddlers are in the blank developmental stage. Piaget talks about cognitive development. That's Piaget. And I know this is a very tricky question for you. I get it. But this is one of the things that you are going to have to try to understand. You're going to see that on quizzes, exams, essays. And Piaget at that toddler stage is all about playing with stuff, touching it in the mouth and moving it around, getting a car and a truck and putting them together and in the mouth and moving them. That's what they do. It's all what Piaget says. They have to see it. Everything is concrete. Which intervention helps a hospitalized toddler feel a sense of control? I mean, it's hard enough to take a toddler ages 1 to 3 on vacation, put them in a hospital. How do you make them feel more comfortable? A sense of control. What do you think would help? Put them on the same routine. Same foods if you can. same time for bath time, nap time, bedtime. This all really helps so they know what's coming next. It really is important. All children reach developmental milestones at the same age. Not, you're absolutely right. You know, I've seen children walking at ages 6 months. My grandson and my two children, I have a son and a daughter, they didn't walk till 15 months and they never walked. All three of them ran at 15 months, all different. Immunizations for a 4-month-old infant. What action should the nurse take to provide atraumatic care for this infant? Atraumatic care. How can you make it not hurt? And it's that pacifier with sugar water. Another thing is what I developed a program for Nicholas Children Hospital System. It's called Huggies. Help us give great injections efficiently and safely. H period, U period, etc. And what I said and I researched and found out, a parent holding their child before, during, and after an injection, that child, even infants, had less pain and stress before, during, and after that injection. So comfort care, holding that child. It's one of the programs that I made. You can Google it, you'll see it. What of the following immunizations can be administered to a newborn? Now I'm going to warn you, if you open the book in chapter 31 and look at infants, you're going to see 2 pages of immunizations. This is one of the ones that you need to know. Which one do we give a newborn? It's usually at birth before they leave the hospital. And it's hepatitis B, okay? Polio, MMR, later on. DTaP is 2, 4, 6 months. The normal heart rate for an infant is what? You're going to give digoxin. The heart rate's 100. Can you give it? There you go. 140 to 160 is an infant. That is what they say. I mean, by the time they get to be 1 year old, the body matures and the heart's better, etc. It's lower, but an infant, 140 to 160 at rest. What is the preferred site to give an injection to an infant? The vastus lataris, which means upper outer thigh, not in the calf, not in the arm, absolutely not. It's that upper outer thigh. That's where they get it. The muscles are there and they move the legs a lot, so it's the best place. The death of an infant under 1 year old with no known cause. You know, teaching pediatrics taught me one thing about this condition. I didn't realize males are more susceptible than females in SIDS, okay? Also, I've always known that breastfeeding was better than bottle feeding. I didn't understand gender. And there's many other things that go with that. And then you're going to be reading about that. And we'll talk about it too. A Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why doesn't she look at the nurse? This is respect in this. You know, you could think it's maybe, you know, she's embarrassed, but no, this is absolute respect for this culture. So understanding that helps you understand that child, that mother. A child from Mexico is hospitalized for a serious illness, and the father says the child's being punished by God. Why is he saying that? And again, this is a belief in the culture from Mexico. This is what they believe. If you're sick, it's because you're being punished. And even younger children believe this too. And we'll talk about that next week. Which term refers to the times in an individual life when he or she is more susceptible to positive or negative influences? This is one of those definitions that we went through a little bit before. And this is called the sensitive period. So open the book, look at the front and look at definitions in each chapter. And it's actually a really good thing for you to do. And then your interactive PowerPoint. What is characteristic of the pre-operational stage of cognitive development? Again, this is Piaget, something that I've sent you a handout for. We're going to be discussing it more next week, but I'm again introducing you to these questions that right now sound like I don't get it. So in pre-operational stage, it's about that preschooler ages. And what they think is they need to see it to understand it. Like if you have a truck that has wheels, you put it down, it rolls. They need to see it. They can't think about it. They can't do it by themselves. They need to understand it by looking, seeing it, concrete. Last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? What does Kohlberg talk about? Moral. What's morality? When you talk about Kohlberg, look for things like actions are good or bad, and there's a consequence for either. And as they get older, they're like, well, it's a bad consequence, but I know what the consequence will be. It's bad, but I'm going to do it because I want to do it anyway. And that's as they get older and understand it more. But they know if they're good, they're going to be praised. If they're bad, they're going to be punished. Number 3 is Amber. Good job, Amber. Number 2, Ashton. Good job, Ashton. Whoop, whoop, whoop. Number 1, Megan. Good job, Megan. Whoop, whoop, whoop. And Shaylin and Chill. Good job, guys. I know that was a little hard because you didn't know a lot of it. So good job. Sign your attendance attestations, please. Make sure they're done because you only have 2 points of reference for this week. Any questions for me at all? I will be posting this tomorrow. Did you enjoy your lecture tonight? Did it keep you awake till 10 o'clock? Good. Yes. Good. Have a great evening. Nice meeting you all. Any questions, anything you need, send me a message. I'm here to help you, okay? Good luck, guys.
Thank you, Professor.
Thank you. Good night.
Bye.